Okay, so this is part 2 of wound healing and ulcers. Already did the O'Sullivan text reading. Now I'm going to do the therapy ed. So like I said in part 1, that's the O'Sullivan text pages, 6th edition, 7th edition. This is what I have. And so we're going to talk about skin ulcers. A venous ulcer. The etiology is associated with chronic venous insufficiency, valvular incompetence, history of deep venous thrombosis, DVT, venous hypertension, calf muscle pump failure, reoccurrence is high, arterial insufficiency may coexist. Clinical features can occur anywhere in the lower leg, common over area of medial malleolus, sometimes lateral. Pulses are normal. Venous ulcer, normal pulses. Pain, none to aching pain in dependent position. So sometimes none, sometimes aching pain in dependent positions. Color, normal or cyanotic in dependent positioning. Dark pigmentation may appear. Liposclerosis, thick, tender fibrosis tissue. Indurated fibrosis tissue. Temperature is normal. Edema is present, often marked. Skin changes. Pigmentation, stasis, dermatitis may be present. Thickening of skin as scarring develops. Ulceration may develop, especially medial ankle, wet with large amount of exudate. Gangrene is absent. Staging for venous, arterial, and diabetic ulcers. Uses partial and full thickness classifications. Differential diagnosis. Arterial versus venous ulcers. Etiology. Arterial, you're looking at arteriosclerosis and arterioembolism. With the venous, you're looking at valvular incompetence and venous hypertension. The appearance. Arterial is going to be irregular, smooth edges, minimum to no granulation, and is usually deep. So arterial is a deep wound. Venous is also going to be irregular, dark pigmentation, sometimes fibrotic, good granulation, and usually shallow. So arterial is minimal to no granulation. Venous is good granulation. Arterial is usually deep. Venous is usually shallow. Location. Distal lower leg, toes, and feet. Lateral malleolus, anterior tibial area. Venous is distal lower leg, medial malleolus. So arterial is lateral, and venous is medial malleolus. So the A in arterial, the A in lateral, LAT, the E in venous, and the E in medial malleolus. That's how I'm going to remember that. Okay, pedal pulses in arterial are decreased or absent. In venous, it's usually present. So arterial absent or decreased. Venous is present. You're present at the venue. Venous present. Pain, painful. Arterials are painful. especially if legs are elevated. So pedal pulses are absent and they are painful. So we can say the A in arterial represents the A in painful. And then in venous, little pain, uncomfortable when legs are elevated. So uncomfortable when legs are elevated is the venous. Venous. Uncomfortable with legs elevated. Drainage, arterial, not present in arterial. No drainage with arterial ulcers. Venous is absent. Wait. Back up. Venous is moderate to large amounts of exudate. So drainage, arterial, no drainage. Venous, moderate to large amounts of exudate. So medial, exudate. Medial malleolus, moderate to large amounts of exudate. Associated gangrene may be present with arterial, is absent with venous. So gangrene is present with arterial, maybe. Venous is absent. Associated signs. Trophic changes. Pallor on foot elevation. Dusty rubor on dependency. So it gets pale when they elevate and red when they're dependent. So pale with foot elevation and red with dependency. With venous, you're going to see edema, swelling, stasis, dermatitis, possible cyanosis on dependency. So that's a really good table. Venous and arterial differential diagnosis, see chart 5.4, and that's what we just looked at. Examination, DVT assessment. Ultrasonography, score of 3 or higher on clinical assessment guideline for DVT. Cuff test and Homan signs have low sensitivity and specificity. ABI and venous filling time. So you need a DVT assessment, an ultrasonography, a score of 3 or higher on a clinical assessment guideline for DVT, a cuff test, and Homan signs have low sensitivity and or specificity. So that's the DVT assessment. Then you got the ABI, and then you have the venous filling time. 6, intervention, C wound care, compression. Contraindicated if ABI is less than 0.7 or active DVT. So compression is contraindicated if ABI is less than 0.7. Other interventions include exercise, patient education to prevent trauma and swelling. A compression wrap that remains in place during the day and preferable also at night is optimal. Arterial ulcer, etiology, associated with, let's see what is going on here. Okay. Etiology is associated with chronic arterial insufficiency, arteriosclerosis, arthroembolism, and history of minor non-healing trauma. Clinical features can occur anywhere in the lower leg, common on small toes, feet, bony areas of trauma, the shin. Preceded by signs and symptoms of arterial insufficiency, pulses poor or absent, intermittent claudication, pain, often severe, intermittent, progressing to pain at rest, exacerbated with limb elevation. Color, pale on elevation, So we got pain and paleness when it's elevated with the arterial. Did he know? So with the arterial ulcer, you have pain and pale on elevation. You have more pain with lymph elevation, and you have more paleness with elevation. Pain and paleness, pain and pale on elevation. Pain and pale on elevation with arterial ulcer. Dusty rubor on dependency. So when they're on the floor, in a seated position or standing, they're probably going to get red. The temperature of the leg will be cool. Skin changes, trophic changes, thin, shiny, atrophic skin. Loss of hair on foot and toes, and nails are thickened. Ulceration of the toes or feet and can be deep. Gangrene, black. Gangrenous skin adjacent to ulcer can develop. Examination. Pulses, temperature, ABI, segmental blood pressure measurements greater than 20 drop between segments is significant. Capillary refill, TCPO2, and outcome measure walking impairment questionnaire. Interventions, see wound care, promote blood flow, medications, surgery, elevate head and bed to promote exercise, patient education to prevent further trauma. So I gotta take a break here because Jenny wants to go pee, I think. Okay, diabetic ulcer. Etiology. Diabetes is associated with arterial disease and peripheral neuropathy caused by repetitive trauma on insensitive skin. Clinical features occurs where arterial ulcers usually appear or where peripheral neuropathy appears. Plantar aspect of foot. Pain. Typically not painful. Sensory loss usually present. Pulses may be present or diminished. Absent ankle jerks with neuropathy. Sepsis common. Gangrene may develop. Examination. Circulation, sensory integrity, myofilament testing, pain, and integumentary. Classification, use the Wagner classification system and partial or full thickness scheme for diabetic foot ulcer classification. Interventions, see wound care, offloading, neuropathic ulcer, total contact casting, removable walking boot, foot care guidelines, and exercise. Okay, so that was the first therapy ed, pages 279 to 280, and now we'll move to 282 and to 286. Wound care, infection control. Wounds are cultured, antibiotic treatment regimen prescribed. Topical antimicrobial agents, for example, silver nitrate, silver sulfadiazine, erythromycin, gentamicin, neomycin, and triple antibiotic. Anti-inflammatory agents such as corticosteroids, hydrocortisone, ibuprofen, topical analgesics, and anesthesics. Lidocaine, and that one. Hand washing of healthcare practitioners. Sterile technique is most appropriate in acute care hospitals and with invasive procedures, while clean technique is most appropriate for home care, long-term facilities, outpatient, and routine procedures. Negative pressure wound therapy, vacuum assisted closure, an open cell foam dressing placed into the wound, controlled subatmospheric pressure, typically 125 below ambient pressure, is applied via specialized device, helps to maintain a moist wound environment, control edema, increases localized blood flow, and reduces infectious material. Surgical intervention, indicated for exercising of ulcer, enhancing vascularity, and resurfacing the wound grafts, and preventing sepsis and osteomyelitis. May be indicative for stage 3 and 4 ulcers. Hyperbaric oxygen therapy. Patient breathes 100% oxygen in a sealed full-body chamber with elevated atmospheric pressure between 2.0 and 2.5 atmospheres absolute, ATA. Hyperoxygenation reverses tissue hypoxia and facilitates wound healing due to enhanced solubility of oxygen in the blood. Contraindicated in untreated pneumothorax and some anti-neoplastic medications. Wound cleansing, removal of loose cellular debris, metabolic waste, bacteria, and topical agents that retard wound healing. Cleanse wounds initially and at dressing change. Normal saline, recommended for most ulcers, non-toxic effects in wound. Cleansing topical agents contain surfactants that lower surface tension. Limited use may be toxic to healing tissues. For example, povidone iodine solution, sodium hypochlorite solution, Dakin solution, acetic acid solution, and hydrogen peroxide. Mechanical delivery systems. 1. Minimal mechanical force. Cleansing with gauze, cloth, or sponge. Irrigation. Recommended pressures range from 4 to 15 psi. Squeeze bottle, bulb syringe or piston syringe, pulse lavage, delivery of irrigating solution under pressure that is produced by an electronically powered device. Pulse lavage with vacuum assists in removal of wound debris. Whirlpool therapy is not supported for wound care. Adverse events with whirlpool therapy can include contamination and infection associated with pathogens found in whirlpool equipment. Higher and unregulated pressures can damage granulation tissue, and limbs placed in a dependent position experience increased venous hypertension and vascular congestion. Pulse lavage with vacuum is more effective treatment alternative. Do not use harsh soaps, alcohol-based products, or harsh antiseptic agents. They erode skin. Wound debridement. Removal of necrotic or infected tissue that interferes with wound healing. See Table 5.6. Allows examination of ulcer, determination of extent of wound, decreases bacterial concentration in wound, and improves wound healing, decreases spread of infection, cellulitis or sepsis. Wound dressings, topical agents, used to manage non-healing or infected wounds. Includes wound cleanser and antiseptics, acetic acid, Dakin solutions, povidone iodine, antimicrobials such as antifungals, nystatin, and antibacterials, bactricin, neosporin, anesthesia and analgesic agents such as topical lidocaine, and enzymatic debridement such as Santil. Ideal wound dressings maintain a moist environment and controls excessive exudate, facilitate gaseous exchange, oxygen, carbon dioxide, and water, insulates, prevents contamination from microorganisms, and non-traumatic to the wound. A moist wound environment facilitates autolytic debridement and promotes faster wound healing with less pain. See Table 5.7. Alginate dressings, transparent film dressings, Tegaderm, bio-inclusive, off-site, foam dressings, hydrogel dressings, hydrocolloid dressings, gauze dressings, standard gauze not impregnated like Kerlix or 4x4s or Telfa, impregnated gauze such as silver, iodine, or Vaseline impregnated gauze like Zetoform, silver dressings, common antimicrobial agent found in foams, films, alginates, hydrocolloids, hydrogels, and other types of dressings. Specialty dressings, wound matrix dressings provide a scaffolding for cellular deposits, typically collagen and hyaluron-based dressing like Prisma, skin substitutes, epidermal, dermal, or both, like Dermagraft. Most are expensive and used when standard wound care has failed. Edema management, leg elevation and exercise, ankle pumps. Compression therapy to facilitate movement of excessive fluid from lower extremity. 1. Compression wraps, elastic or tubular bandages. 2. Paste bandages such as a uniboot that is pliable, non-stretchable dressing impregnated with zinc or calamine and gelatin. Compression stockings such as Jost. And 4. Compression pump therapy. 8. Electrical stimulation for wound healing therapy. See Chapter 10. Used to improve circulation, facilitate debridement, and enhance tissue repair. Continuous waveform application with direct currents. High voltage pulsed currents and pulsed biphasic currents. Nutritional considerations. Delayed wound healing associated with malnutrition and poor hydration. Albumin. Normal is 3.5 to 5.5. Less than 3.5 is malnutrition. BMI. Less than 21 with weight loss, increased risk for pressure ulcer. Provide adequate hydration. Individuals with wounds require approximately 3 or more liters of water a day. Patients on air fluidized beds require greater hydration. Interesting. Provide adequate nutrition. Frequent high-calorie, high-protein meals. Energy intake 25 to 35 calories per kilogram of body weight, and protein 1 to 5 to 2.5 grams kilogram per body weight. Patients with trauma, stress, and burns require higher intakes. And here's table 5-6. Methods of debridement. So, the method is autolytic, a selective method of natural debridement promoted under occlusive or semi-occlusive moisture-retentive dressings that results in solubilization of necrotic tissue only by phagocytic cells and by proteolytic and collagenylytic enzymes inherent in the tissues. Indications. Individuals on anticoagulant therapy. Individuals who cannot tolerate other forms of debridement. All necrotic wounds in people who are medically stable. Contraindications. Infected wounds. Wounds of immunosuppressed individuals. Dry gangrene or dry ischemic wounds. Autolytic. Enzymatic, a selective method of chemical debridement that promotes liquefaction of necrotic tissue by applying topical preparation of collagenylytic enzymes to those tissues. Indications. All moist necrotic wounds, eschar after cross-hatching, homebound individuals, people who cannot tolerate surgical debridement. Contraindications. Ischemic wounds unless adequate vascular status has been determined. Dry gangrene, clean granulated wounds. Mechanical. A non-selective method of debridement that removes foreign material and devitalized or contaminated tissue by physical forces. Wet to dry gauze dressing, dextronomers, pulsatile lavage with suction, and may remove healthy tissue as well. Indications. Wounds with moist necrotic tissue or foreign material present. Contraindications. Clean granulated wounds. Sharp debridement. A selective method of debridement using sterile instruments such as a scalpel, scissors, forceps, or silver nitrate stick that subsequently removes only necrotic wound tissue without anesthesia and with little or no bleeding induced in viable tissue. Indications. Scoring and or excision of leathery eschar. Excision of moist necrotic tissue. Contraindications. Clean wounds. Advancing cellulitis with sepsis. When infection threatens the individual's life. Individual on anticoagulant therapy or has coagulopathy. Surgical debridement. For deep stage 3 or 4 or complicated pressure ulcer, the most efficient method of debridement. It is selective and is performed by a physician or surgeon using sterile instruments such as a scalpel, scissors, forceps, hemostat, silver nitrate sticks in a one-time operative procedure. The procedure usually removes most, if not all, necrotic tissue and may also remove some healthy tissue in what is termed wide excision. Because there may be associated pain and or bleeding, the individual may require anesthesia, and the procedure will likely require an operating or special procedures room. Indications: advancing cellulitis with sepsis, immunocompromised individuals, when infection threatens the individual's life, clean wounds as a preliminary procedure to surgical wound closure line, granulation and scar tissue may be excised. Contraindications: cardiac disease, pulmonary disease, or diabetes, severe spasticity, individuals who cannot tolerate surgery, individuals with a short life expectancy, quality of life cannot be improved. Methods of debridement: kilohertz ultrasound, MIST, M-I-S-T. This long-wave, low-frequency ultrasound typically operates between 20 and 50 hertz. This is a selective form of debridement. Autoclaving of contact probe is usually required. Not all devices make direct contact with wound. Indications: selective removal of necrotic tissue desired. Reduces bioburden. Increases angiogenesis. Wound bed preparation for grafting or flap closure. Contraindications include vascular abnormalities such as DVT, emboli, and advanced peripheral vascular disease, irradiated areas, tumors, organs, or electrical devices, precautions over nerves, infections, and anesthetic areas. Biological method of debridement is rarely used. It is the use of maggots to debride non-viable tissue. They produce enzymes and phagocytize necrotic tissue and bacteria such as MRSA, group A and B strep, and Pseudomonas. They may stimulate granulation formation and epithelialization. Indications: individuals who cannot tolerate other forms of debridement, all non-healing necrotic wounds in people who are medically stable. Contraindications include psychological distress arises from having living creatures in wounds and reports of pain increasing. So the next table is table 5.7, and it's the characteristics of some major dressing categories, dressing category and definition, indications, advantages, disadvantages, and considerations. So I've cut and pasted and combined these two tables together. So I'm going to take a little short break here and let Jenny in. Okay. Characteristics of some major dressing categories. Transparent films, clear, adhesive, semi-permeable membrane dressings, permeable to atmospheric oxygen and moisture vapor, yet impermeable to water, bacteria, and environmental contaminants. Get up there, Jenny. Come on. Okay. Indications: stage 1 and stage 2 pressure ulcers. Secondary dressing in certain situations for autolytic debridement, skin donor sites, cover for hydrophilic powder and paste preparations, and hydrogels. Advantages: visual evaluation of wound without removal. impermeable to external fluids and bacteria, transparent and comfortable, promote autolytic debridement, minimize friction. Disadvantages: non-absorptive. Application can be difficult. Channeling or wrinkling occurs. Not to be used on wounds with fragile surrounding skin or infected wounds. Considerations: allow 1 to 2 inch wound margin around bed. Shave surrounding hair. Secondary dressing not required. Dressing change varies with wound condition and location. Avoid in wounds with infection, copious drainage, or tracks. Transparent films. Hydrocolloids. Adhesive wafers contain hydroactive absorptive particles that interact with wound fluid to form a gelatinous mass over the wound bed. May be either occlusive or semi-occlusive, available in paste form that can be used as a filler for shallow cavity wounds. Indications: protection of partial thickness wounds, autolytic debridement of necrosis or slough, wounds with mild exudate. Advantages: maintains a moist wound environment, non-adhesive to healing tissue, comfortable, impermeable to external bacteria and contaminants, support autolytic debridement, minimal to moderate absorption, waterproof, reduce pain, easy to apply, time-saving, thin, forms diminish friction. Disadvantages: non-transparent, may soften and change shape with heat or friction, odor and yellow drainage on removal, melted dressing material, not recommended for wounds with heavy exudate, sinus tracts or infections, wounds that expose bone or tendon, or wounds with fragile surrounding skin. Dressing edges may curl. Considerations: characteristic color with yellow exudate similar to pus, normal when dressing is removed. Allow 1 to 1.5 inch margin of healthy tissue around wound edges. Taping edges will help prevent curling. Frequency of changes depends on amount of exudate. Change every 3 to 7 days or as needed with leakage Avoid in wounds with infection or tracks. And that is hydrocolloids. Hydrogels. Water or glycerin-based gels insoluble in water. Available in solid sheets, amorphous gels, or impregnated gauze. Absorptive capacity varies. Indications for partial and full thickness wounds, wounds with necrosis and slough, burns and tissue damage by radiation. Advantages: it's soothing and cooling, fills dead space, rehydrate dry wound beds, promotes autolytic debridement, provides minimal to moderate absorption, conforms to wound bed, transparent to translucent, many are non-adherent. Amorphous form can be used when infection is present. Disadvantage: most require a secondary dressing, not used for heavily exudating wounds, may dry out and then adhere to wound bed, may macerate surrounding skin. Considerations. Sheet form works well on partial thickness wounds. Do not use sheet form on infected ulcers. Sheet form can promote growth of Pseudomonas and yeast. Dressing changes every 8 to 48 hours. Use skin barrier wipes on surrounding intact skin to decrease risk of maceration. Hydrogels. Foams. Semi-permeable membrane that are either hydrophilic or hydrophobic. Vary in thickness, absorptive capacity, and adhesive properties. Indications. Partial and full thickness wounds with minimal to moderate exudate. Secondary dressing for wounds with packing to provide additional absorption. Provides protection and insulation. Disadvantages. Insulate wounds. It provides some padding. These are the advantages. It insulates the wound. It provides some padding. Most are non-adherent, comfortable, manage minimal to heavy exudate, easy to use. Some newer products are designed for deep cavities. Disadvantages. Non-transparent, non-adherent foams require secondary dressing tape or net to hold in place. Some newer foams have tape on edges. Poor conformability to deep wounds, not for use with dry eschar or wounds with no exudate. Considerations. Change schedule varies from 1 to 5 days or as needed for leakage. Protect intact skin. Protect intact surrounding skin with skin sealant to prevent maceration. Alginates. Soft, absorbent, non-woven dressings derived from seaweed that have a fluffy, cotton-like appearance. React with wound exudate to form a viscous hydrophilic gel mass over the wound area, available in ropes and pads. Indications. Wounds with moderate to large amounts of exudate. Wounds with combination of exudate and necrosis. Wounds that require packing and absorption. Infected and non-infected exudating wounds. Advantages. Absorbs up to 20 times their weight in drainage. Fills dead space. Supports debridement in presence of exudate and is easy to apply. Disadvantages require a secondary dressing. Not recommended for dry or lightly exudating wounds. Can dry the wound bed. Considerations. May use dry gauze pad or transparent film as secondary dressing. Change schedule varies with type of product used and amount of exudate, from every 8 hours to every 2 to 3 days. Alginates. Gauze dressing. Made of cotton and synthetic fabric that is absorptive and permeable to water and oxygen. May be used wet, moist, dry, or impregnated with petroleum, antiseptics, or other agents. Come in varying weaves and with different size interstices. Indications. Exudative wounds. Wounds with dead space, tunneling, or sinus tracts. Wounds with combination exudate or necrotic tissue. Then you have wet to dry, which is mechanical debridement of necrotic tissue and slough. Continuous dry for heavy exudating wounds. Continuous moist to protect the clean wounds or autolytic debridement of slough or eschar, and delivery of topical needs. Advantages: readily available, can be used with appropriate solutions such as gels, normal saline, or topical antimicrobials to keep wound moist, can be used on infected wounds. Good mechanical debridement if properly used. Cost-effective filler for large wounds. Effective delivery of topicals if kept moist. Disadvantages of gauze dressings include delayed healing if used improperly, pain on removal, wet to dry, labor intensive, requires secondary dressing, avoid direct contact with granulating tissue. Considerations: change schedule varies with the amount of exudate, pack loosely into wounds, tight packing compromises blood flow and delays wound closure. Use continuous roll of gauze for packing large wounds. Ensures complete removal. If too wet, dressings will macerate around the skin. If too wet, dressings will macerate surrounding skin. Use wide mesh gauze for debridement and fine mesh gauze for protection. Protect surrounding skin with moisture-bearing ointment or skin sealant as needed. Injury prevention or reduction. Injury prevention or reduction. Daily comprehensive skin inspection, paying particular attention to bony prominences such as the sacrum, coccyx, trochanter, ischial tuberosities, medial and lateral malleolus. Therapeutic positioning to relieve pressure and allow tissue reperfusion. In bed, turning or repositioning every 2 hours during acute and rehabilitation phases. In wheelchair push-ups every 15 minutes. Use techniques to ensure skin protection, avoid friction, shear, or abrasion injury. Use of sheepskin. Lifting, not dragging. Use of turning and draw sheets, trapeze, manual, or electric lifts. Use of cornstarch, lubricants, pad protectors, thin film dressings, or hydrocolloid dressings over friction risk sites. Use of transfer board for sliding wheelchair transfers. And that's all the reading. Where are we on time? 48 minutes. I really wanted to go back and look at some pictures. Look at some pictures of twins. Wound. Let's see. Okay. There's a transparent film, tegaderm. That's a pretty popular one that you hear a lot of. Yeah. Tegaderm. That's a very popular one. I use that a lot in the hospital right there. This one right here. Oops. Optiskin film. Yeah, I'm familiar with that one, that's for sure. Tegaderm. What else we got here? Okay. So, clear adhesive, semi-permeable membrane dressings for stage 1 and 2 pressure ulcers, secondary dressing in certain situations, autolytic debridement, skin donor sites, cover of hydrophilic powder and paste preparations, minimize friction, promote autolytic debridement, transparent and comfortable, but they're non-absorbent, so you wouldn't use them on a wound that's exudating. Application can be difficult because those little films like to touch on everything. Channeling and wrinkling will occur. Allow 1 to 2 inch wound margin around bed. Dressing change varies. Avoid in wounds with infection and copious drainage. Now let's look at hydrocolloids. Yes. There's an ectoderm. So tegaderm also makes a hydrocolloid thin right here. So there's one. Non-transparent, can't see through it. Protection of partial thickness wounds. Autolytic debridement of necrosis and slough. Wounds with mild exudate. They're waterproof, reduce pain, easy to apply, time saving. Thin form diminishes friction. Conformable, not adhesive to healing tissue, maintains a moist wound environment. Disadvantages is they're not transparent, may soften and change shape with heat and friction. Odor and yellow drainage on removal. Melted dressing material not recommended for wounds with heavy exudate, sinus tracts, infections, wounds that expose bone and tendon, or wounds with fragile surrounding skin and the edges may curl. So here's the oval kind right here. Here's a thin and here's a sacral. I've seen the sacrals. And the edges do curl. I've seen that a lot. Let's see. Taping the edges may help prevent curling. Change every 3 to 7 days. Avoid in wounds with infection and tracts. So if you have any tunneling, that's not going to work. There's a thin one. Thin forms diminish friction. Over different kinds there. Yep, I've seen that one before. Okay, so let's go to the next one. Hydrogels. Let's see, So that was a hydrocolloid. So let's look at hydrogels. Okay, so there's a hydrogel wound dressing. water and glycerin-based gels insoluble in water, available in solid sheets. Impregnated gauze, absorbent capacity varies. For partial and full thickness wounds, wounds with necrosis and slough, burns, and tissue damage by radiation. The advantages is soothing and cooling. Hydro wound dressing. Hydrogel wound dressing, so it fills the dead space. There's a hydrogel. Rehydrates dry wound beds. So there's this available in solid sheets, gels, or impregnated gauze. Here's the impregnated gauze. And there's a sheet. And there's the gel. The capacity varies. Promotes autolytic debridement, rehydrates dry wound beds, fills dead space, provides minimal to moderate absorption, conforms to wound bed, transparent to translucent. Many are non-adherent. In an amorphous form can be used when infection is present. Most require a secondary dressing, not used for heavy exudating wounds, may dry out and then adhere to wound bed, may macerate surrounding skin. Sheet form, which is, that's a sheet form right there, works well with partial thickness ulcers. Do not use sheet form on infected ulcers. Sheet form can promote growth of pseudomonas and yeast. Change every 8 to 48 hours. Use skin barrier wipe on surrounding intact skin to decrease maceration. There you go. Those are examples. Okay, let's move down. Foams. So go back here, go to gel, back. There. Okay. Foam. Oh yeah, I've seen those before. Yep. Semi-permeable membranes that are either hydrophilic or hydrophobic. Vary in thickness, absorptive capacity, and adhesive properties. For partial and full thickness wounds with minimal to moderate exudate. Secondary dressing for wounds with packing to provide additional absorption. So you have to use a secondary dressing on top of those foams. Provide protection and insulation. The advantages is that it insulates wounds, provides padding, most are non-adherent, comfortable, manage minimal to heavy exudate, easy to use. Some newer products are designed for deep cavities. Disadvantages are non-transparent, non-adherent foams require secondary dressing, tape, or net to hold in place. Some newer foams have tape and edges. Poor conformability to deep wounds, not for use with dry escort or wounds with no exudate. Change every 1 to 5 days as needed for leakage. Protect intact surrounding skin with skin sealing to prevent maceration. And there's your foams. Alginates. Let's see. Wound alginate wound dressing. Soft, absorbent, non-woven dressings derived from seaweed that have a fluffy cotton-like appearance react with wound exudate to form a viscous hydrophilic gel mass over the wound area. Available in ropes and pads. Is that the rope? Nope, it's a pad. Looking for a rope. Is that a rope? Nope, that's a pad. Oh, there's a honey. Okay, wounds with moderate to large amounts of exudate, combination exudate necrosis that require packing and absorption, infected and non-infected exudating wounds. So you can use these on infected and not infected wounds. Absorbs up to 20 times their weight in drainage. Wow. So a heavy exudating wound. Okay, there's a rope. There's the rope right there. There's another rope right there. Alginate. Fills dead space. That's probably what you use a rope for. Supports debridement in presence of exudate and easy to apply. The disadvantage is they require secondary dressings, not recommended for dry or lightly exudating wounds, and can dry the wound bed. May use dry gauze pad or transparent film as secondary dressing. So you would use that secondary, that transparent film on top of it. Change schedule varies from every 8 hours to every 2 to 3 days, depending on the type of product you use and the amount of exudate. And those are your algins. Now we're going to go to gauze dressing, and you see a lot of this because of they're usually available and they're cheap. Oops. Here's your gauze. Gauze. Lots of different gauze. Made of cotton or synthetic fabric that is absorptive and permeable to water and oxygen. May be used wet, moist, dry, or impregnated with petroleum antiseptics or other agents. Come in varying weaves and with different size interstices. You can use them for exudated wounds that have dead space, tunneling, or sinus tracts, combination exudate, or necrotic tissue. So you have the wet to dry, which is good for mechanical debridement of necrotic tissue. Continuous dry, which is for heavy exudating wounds. And continuous moist, which is protection of clean wounds, autolytic debridement of slough and eschar, and delivery of topical ease. They're readily available, can be used with appropriate solutions such as gels, normal saline, topical antimicrobials to keep moist, to keep the wounds moist. Can be used on infected wounds. Good mechanical debridement, if properly used. Cost-effective filler for large wounds. Effective delivery of topicals if kept moist. The disadvantage is delayed healing if used improperly. Pain on removal, wet to dry. Requires secondary dressing. Avoid direct contact with granulating tissue. Change schedule varies with amount of exudate. Pack loosely into wounds. Tight packing compromises blood flow and delays wound closure. Use continuous roll of gauze for packing large wounds. Ensures complete removal. It's the packing strips right there. If too wet, dressings will macerate surrounding skin. Use wide mesh gauze for debridement and fine mesh gauze for protection. Protect surrounding skin with moisture barrier or skin sealant as needed. I want to go back to this one. And let's put in wet to dry. See what it pulls. Oh, wet to dry dressing. Wet to dry. Wet to dry. Wet to dry. Removal and applying wet to dry dressings. Okay, and then we have continuous. Let's look at. And so wet to dry is mechanical debridement of necrotic tissue and slough. Wet to dry. And now let's do continuous dry. Dry burn dressings for heavily exudating wounds. Dry burn dressings. It's moist to dry. That's moist to dry. Let's continue. Let's continue. What I want. Okay, continuous moist. Let's see what it pulls up here. Zinc saline dressings. Wet dressings. Protection of clean wounds, autolytic debridement of slough and escort, and delivery of topical needs. This is continuous moist. Superspun saline dressing. That's moist to dry. Okay, that isn't what I want. Okay, so and that's it for this one. So I'm going to stop. See you in the next one.